Bismillah ar-Rahman Rahim. What is high intensity statins? What are their, how they are being used in coronary artery disease? What are their effects on mortality and morbidity? And then we'll be studying certain studies, and at the end there will be take-home message. So I start with first high intensity statins, why and when. Now I'm just presenting a case. There's a male who is 48 years of age. He is human resource director of a large international company. He visited Cardiologist for follow-up. He had MI 12 weeks back, and recently he had stent in his coronary arteries. He has got sedentary lifestyle, BMI of 28.5 kg per meter square. He's non-smoker, no family history of premature cardiovascular disease. There is history of asthma. He's taking aspirin 150 mg daily, along with clopidogrel 75 mg daily, and ivabradine 5 mg twice a day, along with medium intensity statins, atorvastatin 10 mg daily. Now, his different investigations shows his blood pressure was 144/93, so he was mildly hypertensive. His fasting glucose level was 108, that means he was a potential diabetic or pre-diabetic. His serum fasting triglyceride shows it was a bit elevated, 1.9 millimoles per liter. Serum LDL cholesterol was 3.5 millimoles per liter, slightly elevated. And his serum HDL was low, which is very usual in this part of the world. You have got low HDL. Now, his other tests, creatinine clearance and carotid auscultation, were absolutely normal. There was no evidence of retinopathy. That means because of diabetes, there was no organs problems. The treatment consideration was, primary consideration was treating his dyslipidemia. Lifestyle changes as important to help reduce the risk of cardiovascular disease and diabetes. Choose right statin. High intensity statin is needed in this case, and choosing an antihypertensive drug for this particular patient. Now, patients are advised to make a lifestyle change, such as reducing salt intake, taking regular physical exercises, and after 4 weeks, his blood pressure came down. We have used valsartan 80 mg daily, and to address the patient's hyperlipidemia, rosuvastatin 20 mg daily was used, which is high intensity statins. Then again, after 4 weeks, his blood pressure returned down to normal. His LDL cholesterol has fallen to 93 milligrams, but there was no change in HDL and triglyceride. As we know, statins has got no role in triglycerides, and they don't increase the HDL. Now, what are the benefits of lowering the cholesterol? The meta-analysis of 38 primary and secondary prevention trials with more than 98,000 patients in total shows that mortality in coronary artery disease has come down, and the total mortality has come down after using statins in ischemic heart disease. As you decrease more and more cholesterol and LDL cholesterol, the mortality comes down and down. Now, relationship between changes in LDL cholesterol and HDL cholesterol levels and coronary heart disease. We know anybody who's got raised LDL cholesterol level, it increases the incidence of ischemic heart disease. So by decreasing 1% LDL cholesterol, the incidence of coronary artery disease decreases by 1%. While increasing the HDL by 1%, the coronary artery disease risk decreases by 3%. Now, risk factor for cardiovascular disease. We all know the different risk factors which are for cardiovascular disease. One is modifiable and the others are non-modifiable. Modifiable is smoking. You have to stop smoking. Dyslipidemia, that is a raised LDL cholesterol. Now we don't consider total cholesterol, we consider LDL cholesterol. Then we need to have more HDL cholesterol, and raised triglyceride have to be addressed. Raised blood pressure, diabetes mellitus, obesity, dietary factors, thromogenic factors, lack of exercise, and excessive use of alcohol. But there are certain non-modifiable factors like personal history of coronary heart disease, family history of ischemic heart disease, age, and gender. Now, this slide just shows the level of risk associated with smoking, hypertension, and hypercholesteremia. Now, smoking, hypertension, and hypercholesteremia, if you put together, the risk of coronary artery disease goes very up. Now, this is atherosclerotic coronary vascular disease burden. According to WHO, 16.6 million people die of cardiovascular disease worldwide each year. cardiovascular diseases contribute to approximately 1/3 of global death. That means 1/3 of the persons dies because of cardiovascular disease. In 2001, 7.2 million people died from coronary artery disease, and 5.5 million deaths were from stroke, which is again an atherosclerotic heart disease. Now, these are the ACC and AHA blood cholesterol guidelines 2007-13. Now, there are 4 statins which are helpful in these cases. And I'll be discussing what should be the optimal level of LDL cholesterol. Anybody who has got an established ischemic heart disease, that means some procedure has been done, he has an MI, 3-vessel disease, stenting has been done, a bypass, his LDL cholesterol should be less than nowadays 70. But those patients who don't have an ischemic heart disease, but they have got diabetes, hypertension, something, the LDL should not be more than 100. Now, first group, 4 groups, they are benefited from statins. First group, individual clinical atherosclerotic cardiovascular disease, acute coronary syndrome, history of myocardial infarction, angina, coronary or other arterial vascularization, stroke, TIA, peripheral vascular disease. This is the group which is most benefited from statins. Second is the people, individual with primary elevated low LDL cholesterol, like more than 190, they are benefited from statins. Third is the one, individual between 40 to 70 years of age with diabetes. Here you have the secondary prevention, because diabetes after 8 to 10 years leads to ischemic heart disease. So here again, this is the aim should be that we must bring the LDL cholesterol to less than 100. And the last one is the individual without clinical atherosclerotic cardiovascular disease or diabetes, who are above 40 to 75 years of age with LDL cholesterol between 70 to 189 and have an estimated 10 years risk of cardiovascular disease to 7.5%. They are the group of the patient who are benefited from statins. Now, what are the moderate intensity statins? Now, they reduces the LDL cholesterol from 30 to 50%. And they are normally used for primary prevention in patients with diabetes mellitus, or those patients who are at high risk of ischemic heart disease. Now, there are other group that's called high intensity statins. They are used for primary prevention in patients without clinical atherosclerotic cardiovascular disease, diabetes, but risk of atherosclerotic cardiovascular disease is more than 7.5. They decrease the LDL cholesterol more than 50%. Mind it, the medium intensity decreases up to 50%, and the high intensity, they decreases the LDL cholesterol by more than 50%. Now, for patients with clinical atherosclerotic cardiovascular disease like acute coronary syndrome, myocardial infarction, stable and unstable angina, stroke, transient ischemic attacks, coronary other revascularization, or loading dose for patients who are going under angioplasty. Here we have to use the high intensity statins, and we will discuss what are the high intensity statins available nowadays. Now, these are the different intensity statins. High intensity statins means atorvastatin, but here the dose is a bit high. Normally you use 40 to 80 milligram atorvastatin. Now, same result can be achieved with rosuvastatin by half the dose. If you're using 40 milligram atorvastatin, then you have to use rosuvastatin 20 milligram. If you are using 80 milligram atorvastatin, then you have to use rosuvastatin in 40 milligram. Then there are medium intensity like atorvastatin, rosuvastatin, atorvastatin 10 milligram, rosuvastatin 5 to 10 milligram, simvastatin 20 to 40 milligram, pravastatin 40 to 80 milligram, lovastatin 40 milligram, fluvastatin XL 80 milligram, fluvastatin 40 milligram BD, or pitavastatin 2 to 4 milligram a day. Now, what I mean that in high intensity atorvastatin do come in high intensity statins, but the dose is a bit double than what we use in rosuvastatin. Now, high intensity statins for primary prevention in patients without clinical atherosclerotic cardiovascular disease and diabetes, but atherosclerotic cardiovascular risk more than 7.5%. Now, there's a trial, Jupiter trial. Jupiter trial means justification for the use of statins in primary prevention, intervention trial evaluating rosuvastatin. Jupiter is basically a placebo group was considered, and then patient on rosuvastatin. Now, there are different age, different factors, the age, sex, race, they were more or less same. Again, current smoker, family history, metabolic syndrome, aspirin use, more or less same in placebo and rosuvastatin group. Now here's the point. Now with rosuvastatin, the time of first occurrence of cardiovascular death, non-fatal strokes, non-fatal MI, unstable angina, or arterial revascularization, there is a marked difference with rosuvastatin compared to placebo. So mortality again was marked difference between placebo and rosuvastatin group. So summary of Jupiter trial is that a 44% reduction in primary endpoint of major cardiovascular events like cardiovascular death, MI, stroke, unstable angina, arterial revascularization was observed in patients who received rosuvastatin 20 mg compared with placebo. Again, a 20% reduction in total mortality was observed in patients who received rosuvastatin 20 mg compared with placebo. Then in Jupiter, long-term treatment with rosuvastatin 20 mg was well tolerated in nearly 9,000 study participants. The result from Jupiter highlight the importance of high efficacy of statins, high intensity statins, treatment for those patients with increased risk of cardiovascular disease. Now, this is an IVUS or intravascular ultrasound picture of patient with atherosclerotic cardiovascular disease. Now, how there is a regression, role of high intensity rosuvastatin in slowing atherosclerotic progress. Establish a trauma in the artery. You use this, and after using these drugs, there is marked regression in trauma. Measuring the effect of intima media thickness and evaluation of rosuvastatin, and this is called Meteor trial. Again, background is to elevate the effect of rosuvastatin compared with placebo on carotid intimal thickening, carotid intimal medial thickening over 2 years among asymptomatic patients at low risk for cardiovascular disease. That means those patients who are asymptomatic having some thickening of the carotids, rosuvastatin compared to placebo was used, and then you can see the results. Now, the study design is the rosuvastatin 20 mg 702 patients and placebo 282 patients. The primary endpoint is annualized rate of changes in maximum carotid intimal medial thickening. And here you can see the difference in placebo compared to rosuvastatin. There is marked regression in thickening of the intima media of carotids. This was secondary endpoint. Now, it is another study that's called Saturn study. It compares the progression of coronary atherosclerosis for two high efficacy statin regimes with different HDL effects. Objective is to compare the effect of rosuvastatin 40 mg versus atorvastatin 80 mg on progression of coronary atherosclerosis assessed by intravascular ultrasound. Now here the study shows that 40 mg of atorvastatin compared to 20 mg of rosuvastatin, and then 40 mg of 80 mg of rosuvastatin compared to 40 mg rosuvastatin. There is marked difference in regression of atheroma. Again, this trial shows that 4,255 patients screened and 1,578 patients treated at center in North America, Europe, South America, and Australia. Treatment for 2 weeks with atorvastatin or rosuvastatin 20 mg for 2 weeks to achieve LDL cholesterol less than 116. And here you can see in 24 months after the treatment, IVUS was done, and that showed 25% patient had a reduction in the atheroma. Primary IVUS efficacy parameters. Here you can see the difference between atorvastatin and rosuvastatin. Secondary IVUS efficacy parameters. Now, comparison of efficacy and safety of rosuvastatin versus atorvastatin, simvastatin, and paravastatin across doses. Stellar trial 2. Stellar trial is 6 weeks, multi-center, open-label, randomized trial was done. 15-arm trial comparing the efficacy and safety of rosuvastatin with atorvastatin, simvastatin, and paravastatin. 2,240 patients with hyperlipidemia or mixed hyperlipidemia were studied. Patient with more than 18 years of age, stable LDL cholesterol concentration of 160 and 250 milligram at the two most recent conservative visits before randomization. Now here 10 milligram rosuvastatin, 20 milligram and 40 milligram rosuvastatin along with other statins were used. In sterile trial, rosuvastatin 20 milligram reduces LDL cholesterol by 52%, while the other reduces less than 50%. In sterile trial, 9 of 10 patients with hyperlipidemia achieved their LDL goals with rosuvastatin 20 milligram. Achievement of LDL cholesterol less than 100 and atorvastatin in the patient with hyperlipidemia or mixed lipidemia, it does reduces, but not to the efficacy of rosuvastatin. Take home messages: use statin to treat the risk. Don't treat the cholesterol. You use a statin to treat the risk. You have to prevent certain deaths. High intensity rosuvastatin provides superior LDL reduction. As I said, anybody who's got established coronary disease, the LDL cholesterol must be less than 70. It provides superior primary prevention, provides superior atherosclerotic plaque regression, and beneficial for a patient undergoing PCI. Thank you very much. Any questions? Now, first is Dr. Swail from Rawalpindi, and that's a question on myalgia. Now, statins, they do produces myalgia. Now, the proven fact is that those who produces less incidence of myalgia are rosuvastatin and pitalovastatin. If they produce myalgia, you have to reduce the dose. But frankly speaking, all the statins, they do produce myalgia. Now, international figures, it should be less than 0.5%, but our population, people probably have got more incidence than international figures. So my experience is that if someone is getting myalgia with one statin, you can use the other, you can change it, but reduce the dose and just two drugs which produce less myalgia or rosuvastatin and pitalovastatin. Another question. Okay, no question. Thank you very much.